Hi, and thank you for joining me for the Let's Talk About Infertility event. Today we've got Marnie, who is an embryologist, who has kindly offered to answer some questions for us. So I'm just going to ask her some questions that I found have been frequently asked in the group. So hi, Marnie.
Hello.
Thank you so much for agreeing to talk to me today. I really appreciate it.
You're welcome. Not a problem.
Okay, so to start off, what affects embryo quality then? Is it the egg? Is it the sperm? Could it be a mixture of both?
That's a really good question, and one that we get asked an awful lot. Unfortunately, there's not a straightforward answer. It's one of those questions that's got potentially many answers, and to try and keep it as brief as possible, a lot can affect the embryo quality. We're all born with our eggs, so we've got our egg supply when we're first born. So genetically, there's nothing we can do. We've got what we've got. How we look after our bodies can have an effect on how those eggs develop, and the quality of them later on down the line. Diet, smoking, things like that has been shown to have an effect on egg quality as well as sperm quality. For men, just a bout of flu can knock the sperm count out, knock the motility down, things like that. Again, one thing that anybody going through for fertility treatment of whatever level will always be advised to make sure you're having a healthy diet, supplements, and things like that, to try and make sure that the eggs and the sperm that we're getting to work with in the laboratory is as good as possible to start with. Embryo quality then can be linked to, if you've got a good egg and a good sperm, in theory you should get a good quality embryo. We're humans and it never quite works that way. If you've got poor eggs and good sperm, or good eggs and poor sperm, you can get a mixture of embryos developing. Laboratory wise, we try and maintain as close an environment to inside the womb as we can manage, but it's not easy when you're talking about metal boxes rather than human skin and flesh. We're not too sure if any of the effects that having the embryos and the eggs and the sperm in the lab can have on the quality of the embryos. There is talk that maybe there are slight changes that can affect, which is why we're always so careful about monitoring the embryos and not just pulling them out and looking at them at any point. But yeah, lots of different things. It's not an easy question to answer.
And you mentioned a few lifestyle things there. Is there anything else that people can do to help improve the quality? Anything, they can do themselves?
Yeah. Main advice is sort of like what we class as general common sense, reducing the alcohol intake, reducing smoking, cutting out smoking altogether would be much more beneficial. For men, you don't want to be taking any protein supplements if you go to the gym a lot, or any of those drugs can have or even the powders, sachets, depending on how much you take, can have a negative impact on your sperm, and sometimes does catch men out. So if any men are taking anything like that, they need to really be seeking advice from their fertility doctors and nurses, and take it from there. Other than that, there are the supplements out there. The well woman, the well man type multivitamins, which we would recommend. Certainly men need to be making sure they're getting their zinc and selenium. That's the old sort of school way of thinking. And there are supplements out there, and just to be careful to shop around, make sure that you're getting a good quality multivitamin rather than the cheap one that may just not have the right amount of the dose in there.
Yeah. Okay, brilliant. Thank you. So some great advice. I hadn't realised about like the protein supplements. I'd not heard that before. So that's great advice for.
Yeah, we've seen that a couple of times where patients have had a sudden decline in sperm count, and looking back, and they've just, whether they're professional athletes or just someone that really enjoys going to the gym and is trying to get their body to the best that they can. I don't know offhand particularly which products would be detrimental, but I know that we've had patients where that has been put down to them taking those supplements or those protein shake type things.
Yeah. Oh, well, that's great. Thank you. And then in terms of the embryos, how do you grade the embryos, and what do you class as good? What do you look for it to be classed as good and high quality?
So an embryo should follow a particular timeline. So you'll hear an embryologist talk about day 2, day 3, day 4, day 5, possibly even day 6, and an embryo should be at a certain stage of development at each of those days. So that's the first thing we're looking at, is the embryo on day 3 where it should be? Is it 6, 7, 8, 9 cells? If it is, then that, that's better than if it's still at the 4 cell stage. What we then want to see is how well those cells have divided. So we're looking at the evenness of the cells. An 8-cell embryo should have 8 cells, all very similar in size. If there's one cell that's too big or too small, it could just be an indication that the division of a cell hasn't occurred evenly, and therefore there could be a disproportionate amount of genetic information in each of the cells. So we grade them, and in our laboratory we grade sort of from a scale of 4 down to 1. So 4 is the top and 1 is the bottom. So 4 would be a really even one, 1 would be a really uneven spread of cells. Then we look at fragmentation. So when a cell divides, how smoothly and cleanly is the cell dividing? And I tend to use the analogy of a bread roll. If you're making a sandwich and you don't use a bread knife and you just pull it apart with your hands, if you get 2 decent bits of bread, then that's fine. All the fragments that we talk about in the embryo, like the breadcrumbs that fall away, a few breadcrumbs on the breadboard you're not going to notice. It's not going to have a negative impact on your final sandwich. But if your bread bun completely sort of starts to disintegrate and you've got lots of bread on your breadboard and not much in your hands, your sandwich is going to be a bit more difficult to eat and not hold together as well. And it's like that with an embryo. The more fragmentation there is, the harder the cells will be able to talk to each other, and the development then tends to not be as good. So again, the fragmentation is 4 for not very much fragmentation, so sort of less than 10%, down to 1 where you're talking sort of over 50% of the embryo has got fragmentation in. Grading then gets a bit more complicated when you get into blastocysts, but again, it's looking for the 3 different things that you want to see with a blastocyst. So how expanded has it got? And then you're looking at the 2 structures of the cells within the blastocyst, and they get a grade from, depending on which scheme and which laboratory. We use an letter system, so A would be the better quality, down to C, Ds and Es, which are the poorer quality or showing degeneration. A lot of it is just how you look at an embryo and see it, and with years of experience, the embryologist can tell a good embryo from a bad embryo very quickly.
Yeah. And then that would then determine whether you did a 3-day transfer or a 5-day transfer on with a blastocyst.
Yeah. And different labs have got their different protocols of how they do it. For example, our lab, we would do the majority of day 5 transfers now. We have some patients that still have a day 3 transfer, and that's normally if we can tell on day 3 that they've got the best embryo selected already at that point. So if we've got either they've only got 1 embryo or they've only got 2 and we'd be putting 2 back anyway, then we might do that and just get the embryos back where they naturally should be. If we can't make the decision on day 3, then we would postpone their transfer until day 5 and hope that we get a bit more information about how the embryos are developing. And actually, as it is, we've just decided in Leeds that as of probably the new year now, all our patients will go to day 5, because we're finding that our pregnancy rates and success rates, the utilisation rates of our embryos is actually at a level that we're all really happy with.
Right.
That we're just not going to interfere and handle the embryos unnecessarily on day 3 anymore.
So what would happen if, looking at an embryo, you didn't think it would make it to day 5? Would you then say it's not worth transferring back, or would it be a case-by-case basis?
It's case by case. Anyone that's coming through for treatment or works in the field knows that we can't group patients together. Everyone is so unique and so different, and it's very difficult to to sort of group your patients together. So there's a certain amount of case by case discussion that goes on in the lab, and a lot of it depends on how the patient feels as well. Ultimately, we're only there to recommend. Quite often the patients will take our recommendation as the best thing, and they're happy with that. Other times the patients have got strong feelings one way or the other about what they would like to do. So this conversation then going as to what's best. If you've got an embryo that we're not particularly happy with, yes, we could put it back, because we don't want to risk in 2 days' time not being any further advanced. The patient then would feel like they've had a transfer, they've given that embryo the chance. Other patients feel that they would prefer to leave the embryo out for 2 days and see if it gets to blastocyst, and if it does, great, or if it's still developing to a certain degree, great, and then we can do the transfer then. If it hasn't, then they know then that the embryo is not going to go anywhere. We would possibly then have to have that discussion about whether we cancel the transfer or go ahead, and again, that's case by case. Doctors and patient and embryologists would have that discussion. Sometimes patients quite like the fact that they could end it there if it's not gone well, rather than having a 2-week wait for a pregnancy test. Yeah. Again, it's personal choice, and scientifically, clinically, I don't think there's a right or a wrong way of doing it.
No. And certainly emotionally, knowing how I felt going through it, because I had to have a freeze all on all of my embryos, I was desperate to have a transfer. So I can see it from why people would want to, but then you put it, if you already know that it may not go, it may not take, you're putting yourself through a lot more heartache with the wait and the test. So I can see why it would be a difficult conversation to have.
Yeah. And patients come up with lots of different reasons why they prefer one way or the other, and a laboratory or a clinic should be supportive of what the patient wants, because I personally am a strong believer that how the patient feels can have a massive impact on whether their cycle's going to work or not. Might just be a placebo, but if a patient feels happy and calm, then I can only think that that's a much more suitable environment for an embryo to try and implant than someone that's highly anxious and highly strung and too emotionally charged about it. Yeah,
definitely. And for them, it's a better experience if they can try and keep calm and aren't worrying about it as well. So no, that's great. And then in terms of freezing, I know when we've spoken before, you're now moving towards only freezing the higher quality embryos. Could you explain why that isn't?
Our policy at Leeds is to only freeze sort of on day 5. So we do day 5 or day 6 freezing, so anything that's a blastocyst. We don't do any freezing other than that anymore, and we do vitrification now, which is like a fast freezing method. We started off freezing anything that had reached the blastocyst stage, and looking back at our success rates from that, so the number that survived the freezing and thawing process, and then the number that led to pregnancies, both those statistics were quite low. So to improve that, to make sure that we're not giving the patient false hope, ultimately, yes, there's a certain amount of the unit statistics need to be good, but ultimately we want to be making sure that we're offering patients a decent treatment option. We're quite pernickety now about what we freeze, and I think a lot of units are also like that. And our patients understand that we only want to freeze something that we feel has got a good potential of leading to a pregnancy. So it might mean that we don't get that many frozen. And I think we're freezing about 20-25% of our cases at the moment. But it is ultimately a bonus if you get freezing. For a patient that doesn't get freezing, it's not having a negative impact on their overall chance. It's one of those things.
Yeah, and you're then more likely to get a positive because you're freezing the ones that could stand a chance rather than going through numerous cycles, which costs and is emotionally and physically, challenging on your body. You're then giving yourself the best chance by only freezing.
Yeah, definitely. Yeah.
And there's been quite a lot of talk, I know, about add-ons and things, and one of those is the Embryoscope. And there's a lot about whether people should use it, what the benefits are. Could you just explain your view on that, please?
Firstly, with regards to add-ons, it is like the phrase of the moment, isn't it? And I don't know if your patients sort of use the HFEA website, but they have started a traffic light system on there for patients with regards to the add-ons that are available in some units, which Embryoscope or time-lapse imaging is one of them. And the HFEA have collated data and have decided it's green, it's something they're willing to have units offering to their patients, and hopefully ultimately become a standard treatment one day, through to red, where they think it's actually unreasonable for a unit to be offering it as a treatment option. Embryoscope at the moment is amber, as are quite a lot of things on the website actually, because I had a quick look last night just to see what colour everything was on. So like a lot of things in the field at the moment, there's good news coming out about it and not so good news. We've had embryoscopes in Leeds now for several years, and we actually have 5 of the embryoscopes, which is a large number for an IVF unit to have. We still have it as an add-on system. There are units out there that don't have it as an add-on anymore, and it is part of the package, and all our patients will go into a time-lapse imaging incubator of one description or another. From a laboratory point of view, I actually quite like them. I like the information you can get. I like to see how an embryo develops, but for us it's very much a deselection method. So we can see that an embryo has misbehaved, should we say. It's not followed that time pathway correctly. So we can say, okay, that one's done something, we're just going to keep an eye on that and move it to one side. Statistics and pregnancy rates, we're seeing some benefits in certain groups of patients, but that's changing all the time, and it's worth having a chat whichever clinic your patients are going to find out if they've got the time-lapse imaging, what the statistics are, and whether they're in a group that would be recommended it or not. It's difficult. I'm very on the fence, and I don't just mean to be awkward just for the sake of this interview. I'm like this at work as well. I can argue one day that I think everybody should go in the Embryoscope, and then I can argue the next day that actually for the money that unfortunately we have to ask for it, I find it very difficult to justify. I certainly think if a patient is sort of like in the older age groups, and therefore in theory the embryos are a bit more likely to behave unusually. We're not necessarily going to see whether the embryo developing is genetically normal or not. That's probably a different question you'll ask me later on. But we can see if it's behaving as it should. Is it dividing at the correct time? So we can glean a lot of information. For some patients it really does help, certainly from our point of view, which embryo we select for transfer and for freezing. And then there are other patients where we would have made that decision anyway, whether we'd have had this information or not. And it's just going to probably take a few more years, I think, before we really see the true benefit of how it works. A lot of it is, I've got some colleagues that spend an awful lot of time working on the data that we get from the Embryoscope and trying to get the algorithms that the system uses to meet the patient groups that we have. And it's an awful lot of work trying to tailor it so that it suits your unit with your media, your protocols, and your patients. But ultimately, I think it's a good thing. I just, like everything, I wish patients didn't have to pay any extra for it. And then I would be more happy to say everybody should go in the Embryoscope.
Yeah. So it's maybe something people need to do their research on beforehand, you know, and have an idea about whether they want to use it, whether it be a benefit, and maybe speak to their consultants about their views.
Yeah.
Because then things like age can be taken into account.
Yeah, I think there's certainly the argument that, you know, maybe the younger patients that in theory are going to do well don't necessarily need it. But then there's the argument that if they're willing to pay the extra money for it, they could do it on their first cycle. It might give us that bit of information that means that they only need the one cycle. Yeah. It could be just a case of have your first cycle, see what happens, see what the embryos develop like, and then maybe have that decision about whether you use it for the second time. There's no right or wrong answer as long as the patient's happy with the decision that they're making and what they're being advised.
Yeah, so just being as informed as possible is the best way before. Another thing we hear quite a lot about is NK cells, so the killer cells, and I know quite a few people from the group have mentioned that it's something that they're getting tested for. How can they affect embryos? And, you know, I've heard it mentioned quite a lot with recurrent miscarriage being looked at for there. What's your view on that? Because
I think the natural killer cells, and this is my personal opinion, this isn't necessarily a unit opinion, but mine is that on the HFEO website they should have a red circle. Scientifically, yes, there is that theory and the natural killer cells are there and what have you. If testing a patient for it, I'm just a bit dubious, and I would struggle to say any more than that, really. I feel some units are possibly too quick to offer it. I think it's something that patients read about, and you know, the phrase natural killer cells, it's kind of got that very emotive response to the, you know, that title. I think a lot of patients sort of cling on to it and think that it's something to go with, and I don't necessarily think it's the correct thing to be offering to a lot of patients. Again, I think it needs to be a lot of discussion between the patients and the consultants, maybe a second opinion, but just be wary who is suggesting it and offering it.
Yeah, I believe there was a Panorama program where it covered it. I think it was talking about add-ons last year or early year, and I think that was covered in it as well, about just being wary because it's another thing that you are charged for, and you can be charged for treatment for it that isn't always necessary. So again, your view your view is to speak to your consultant and maybe get a second opinion, do your research on it before just kind of going along and handing over more money.
Exactly. I think there's a time and a place for that kind of a test, and I think it's edging out into more people are being offered it or wanting it and being given it, rather than being told actually you're not necessarily in the category of patient that it would work. Maybe there's a place for it with the recurrent miscarriage side of treatment, but again, that's not an area that I'm particularly up to date with, and so I would be hesitant about ruling it out for that group. But certainly as a normal test for someone coming through for infertility treatment, I'd be very wary if it was being offered to you.
All right, thank you. That's really helpful. And then the test that you mentioned briefly about the genetic testing. So what happens with genetic testing? What's the benefit of that?
Okay, so we are just in the process of getting our license at Leeds, so it's not something that, again, I've got a lot of experience at. Maybe in 6-12 months I'll be able to speak a bit easier about this for you. There's the difference between the PGD and the PGS. So basically you've got the option if you have a child that's affected with a particular disease or it runs in your family, you can have your embryos screened to make sure they don't have that particular chromosomal abnormality, for example. Or there's PGS, which is the screening, which is more like commonly called like an aneuploidy test. So that's more counting the number of chromosomes in an embryo and is it normal. Again, there's certain patients that this would work for and certain patients that it's just taking money for no particular reason. Hand on heart, I'm not 100% sure who we're going to be offering PGD and PGS to, and in our unit, PGD is slightly different. You come in with Huntington's or you can have down to quite specific disorders that the units will either be licensed to test for, or you can apply directly to the HFEA for, to avoid having a sibling or a child with this particular disorder. And that gets, you know, the genetic team involved as well as the fertility team. Your patients that will need PGD will probably already know probably a lot more about it than I do at this point, because it's something that they'll have had discussed. PGS is a bit more controversial, I suppose, in the fact that some units are offering it to a lot of patients. Whether that's right or not, I don't know. I think, again, it's something that hopefully will be offered to patients that have had more than one failed cycle, as a way to try and make sure that we're putting back an embryo that has got the correct chromosomal complement that it should have. It's all good science and it always does the right thing. Again, it's how it's offered and who it's offered to that's the, you know, the thing that you just need to be really careful for.
Yeah, it's not necessarily worthwhile on, say, your first cycle. If you don't know that there's any issue or that it will fail, then it's not necessarily worth paying that extra money for it at that point. It's something that can be checked if you're finding you're having multiple failed cycles and looking for a reason for it failing.
Exactly. And, you know, going back to sort of the conversations, people wouldn't have been sort of over this way, but sort of 15, 20 years ago when ICSI was just becoming popular, there were units that were like, we're going to do ICSI on everybody. And I know there are clinics around the world where they don't do anything, they don't do routine IVF anymore. Everybody has ICSI. Now, to me, that's offering a treatment that's unnecessary. For me, I think IVF and ICSI need to work together, and there's a definite group of patients where you would offer ICSI to. You can sit there in front of a patient and say, looking at your history and your sperm sample, we recommend doing ICSI, because if we don't, you run a very high chance of the cycle not working. And I think we need to be able to have that conversation with our patients about whatever we're offering them. Especially something as invasive as PGD and PGS. You know, you're here, we want to get you to the end line, which is a pregnancy, and yes, I feel that this will have some benefit on it being more successful, or no, it won't. It's just being very careful about who it's offered to.
So with the PGS testing, is it a case of once their embryos are taken, they then go through a screening process at that point?
I'm not sure if the protocols are the same everywhere, but basically you get your embryos. The embryos are biopsied, so a cell, or depending on which stage you do it at, again, that can vary, but then the embryos are frozen until the results come back, and then we would be able to thaw out the embryo that has come back with an all clear, as it were.
So it would be a case of, in that cycle, everything would be frozen, because you'd have them tested frozen and then have it as a frozen transfer.
Yes, I believe so. I don't think there's the turnaround at the moment for us to be able to do anything other than that, though. Apologies if I'm wrong on that.
I'm not sure at all.
Someone will tell me.
So, thank you. Well, thank you so much. Just as a last thing, what would be your top tip or recommendation for people that are going through IVF?
That's a tricky one. Okay. If you're going through for IVF, I would do as much research before you start your cycle as you feel comfortable with. Just because your friend down the road has been on Google and, sorry, I the search engines are available, all night looking everything up, doesn't mean to say that that has to be. If you're comfortable just being told the information from the clinic, leave it at that. I would be very wary about internet searching. Certainly the further you go on in your cycle, I'm sure you can agree that you become much more emotionally charged when you're going through a cycle. Everything becomes slightly out of proportion, and I don't mean that disrespectfully. I think little thing becomes a big thing. So I would certainly get to the point of starting your cycle, and then that's it. Don't look at the internet anymore.
Yeah.
And make sure that you're happy as a patient. If you're happy with the information that's being given to you, great. And all we want is for our patients to get pregnant as much as our patients want to get pregnant. If there's questions, and ask them. And if you're unhappy, say that you're unhappy at that point. Don't sit and stew. And the old cliche, I could play cliche bingo with this question actually. Try and stay as calm as possible. I appreciate everyone listening to this is like, how can I stay calm? But ultimately, what's going to happen will happen. The lab are going to try the best for you, the clinicians are going to try the best for you, the nurses are going to look after you the best that they can. As a patient, you need to look after your body, you need to look after each other as a couple if you're coming through as a couple, and just see how it goes. Best of luck.
Oh, thank you. That's great advice. And yeah, I would recommend be, like you said, sort of do your research, be as informed as you can be, so that you understand why you are having certain treatments or why you're not having certain things or why they're not recommended. Speak to the consultants, and then trust what they're saying, because they're the experts. And if you've asked all the questions and you're fully clear, then you can feel calmer in the knowledge that you're in safe hands and that you shouldn't need to worry about anything, which, like you said, is the best state to be in, isn't it?
Definitely. Yeah. I mean, we have patients that come through that know, really scientific details about how embryos develop and things like that. But then we have patients that don't know that you need an egg and a sperm to make an embryo. So we see all sorts of patients coming in with all different levels of understanding, and it's whatever. Get to a level that you're happy with. Don't expect to know everything, and don't get upset if you don't know everything, or don't get upset if you don't understand everything. That's what we're here for, is to explain it to you. And don't get upset if you're not told everything at the beginning. We try and sort of almost like drip feed the information to the patients as they go through the cycle, so that we're not overloading you on day one with everything. It's okay, this is as much as you really need to know at this point. We'll tell you in the next step what you need to know at that point. So yeah, it's trusting, but also knowing when you need to ask for more.
Oh, that's brilliant. Thank you so much. That's been really, really helpful. Loads of great information in there. So thank you very much for your time.
Okay.
Take care, and thank you.
Thank you.